Hello, everyone. I'm Marta Gostiljac, and I work in Clinic for Psychiatry, the University Clinical Center of Belgrade. I'm a clinical doctor, so I'm still not the psychiatry trainee, hoping to become one very soon. I'm here on behalf of Maja Pantovic, my dear colleague and mentor, and I will try to simplify the bipolar spectrum disorders, mainly by taking about the approach and paradigm, less talking about neurobiology and more about treatment. So I would like to start the presentation with the citation from the Marner's article from 2006, and it's the first sentence in his article called Beyond Kraepelinian Dichotomy. Nature does not take leaps. There are always overlaps, bridges, or something else in between. But why should Psyche, the most beautiful daughter of physics, take leaps, even when she's ill? Because Emil Kraepelin decided so over 100 years ago. We are going from categorical to dimensional approach, or are we going? So the bipolar disorders are mood disorders, and they are very severe mental disorders. They have very pleomorphic clinical representations. And what does it include? It includes a variety of symptoms, including the affective ones and the psychotic ones. When it comes to dimensional approach, in the majority of the last century, they were considered, the bipolar disorder and the schizophrenia was considered the completely distinct entities when it comes to nosology and etiology. But that was leaving the clinicians very confused what to do with the symptoms in between. The symptoms that they didn't know, do they belong to the bipolar disorder or the schizophrenia? So the new paradigm introduced the concept of spectrum, where they are no longer considered as separate entities, but maybe as a spectrum. Spectrum that include affective symptoms on one end and the psychotic symptoms on the other. So zooming into the affective end of the spectrum, the clinicians were facing another categorical challenge, the one being unipolar and bipolar distinction. Again, this distinction left undefined so many affective symptoms, which, like mixed states, hypomania, less than manic excitement. So the new paradigm proposed that the bipolar disorder is a broader concept than it used to be, and it includes all of the affection manifestation, excluding the unipolar depression. So the epidemiologically and phenomenologically considerations and the biological proofs now speaks more in favor into the continuum approach than the dimensional approach than the categorical, whether on one hand it is a continuum of psychopathology, and maybe overly simplified, we can say that the bipolar spectrum lies between schizoaffective disorders and the major mood disorder on the other hand. But there is one more dimension that I would like to talk about. It is the longitudinal dimension or longitudinal approach, also known as staging model. This approach takes into consideration the time or the progression of the disease over the time. There is so many evidence that proves that every exacerbation of the illness makes our patient more vulnerable to the new episodes, and the neuroprogression is underlying all those. manifestations. So something about the history of the continuum approach in psychiatry. In the ancient era, clinicians were facing the lack of classification, and the psychiatry was considered more as a demonology than the science. But the major shift happened at the end of the 19th and the beginning of the 20th century in all fields of human thoughts and creations. It is important that previously mentioned dichotomy by Kraepelin, who divided endogenous psychosis into the dementia precox and manic depressive illnesses. It is the first time that the first concept of classification. Maybe the first time that this continuum appeared in the paradigm, but not that phrase, the continuum, was presented by Bleuler and Kretschmer, and they saw the schizophrenia as a syndrome. Also, they considered the continuum from normal to pathological states. After 30 years by the previous infamous dichotomy by Kraepelin, he started to change his mind and also was talking about the overlap of the symptoms. Next couple of decades were the one for the categorical approach, but then in the 70s, some kind of revolution happened. The Akitskal and other authors felt the need for the broader concept, the one that will take into consideration biological foundations. So they were starting to talk about the continuum of bipolar disorder. These paintings presented in the slide is one from Munch, and I choose to present him because he was suffering from bipolar disorder. When it comes to neurobiology, I'm so grateful that my colleagues went in such depth when it comes to neurobiology, since it was very overwhelming for me in this state of my training to talk about these complex molecular mechanisms. So I'm just casually gonna skip them and went straight into this slide, not because of the neuroimmunological seesaw or the dual role of inflammatory mediators, but because of this cute monkey, this great painting by our famous artist Mitja Popovic, which exhibitions his exhibition is now taking place in the Belgrade. So if you are in Belgrade, that's the huge recommendation to visit the exhibition. Only after taking into consideration everything previously said, we can now proceed to treatment. As we could see, the bipolar disorder is very multidimensional condition, so we need a multidimensional approach to treat it. This slide, or this red dot here, is representing our patient, and it is a reminder that we always need to think where is our patient standing in the continuum of psychopathology, as well in which stage of the disease. So the question is how to treat so many phases of the disease. The disease that has two phases, acute and the maintenance phase, three groups of symptoms: mania, mixed mania, depression, and as we see, all in between. The three types of polarity: manic, depressive, without predominant polarity. And where is place for antidepressants, antipsychotics, and mood stabilizers? And are those the precise name for these drugs? This table represents the FDA-approved drugs from 2004, and we see that there were several drugs, mainly for the acute bipolar mania, and the biggest challenge was the treatment of acute bipolar depression, as well as the maintenance treatment. 20 years later, we can see that the first column, that the list of medication hasn't gone under the great alteration, but the indication changed. We are now having more and more indications for the same drugs, but again, we are facing the challenge for treating the acute bipolar depression. Well, the changes in paradigm when it comes to diagnosis, it is really, I'm so sorry. It's logical that there are changes in treatment in paradigm as well. There are more complex mechanisms of actions, hoping to find the one that fits all sizes. And now the second generation antipsychotics has a new phase. They no longer belongs only to schizophrenia and more precisely the psychotic symptoms. They are now indicated for all types of affective manifestation, excluding the unipolar depression. The new nomenclature is also proposed. It is the neuroscience-based nomenclature, which is more based on pharmacological mechanism than the actual indications. Fortunately, the drugs we are using, they do not recognize the treatment, the disease they are treating. They just have their targets no matter the diagnosis. So, instead of the conclusion, another painting. This one represents the work of Claude Monet from 1892 to 1894. And it is representing the same cathedral in the different times of day, different times of year. And what does this have to do with the bipolar patient? It very artistically and visually represents the many phases of the bipolar disorders. So our patient is accumulation of his or her life events, starting with the genetic vulnerability exposed to environmental factors, standing somewhere on the pathophysiological continuum and in some stage of the disease. When it comes to biology, the main question maybe remains, are we closer to finding biological biomarker? Well, there isn't a smoking gun yet, but we can see that there's a definitely biological crime scene that are, as we saw in the previous presentations, are very, very, very profoundly investigated. So when it comes to treatment, we are not only the treatment, the paradigm as well. We are still in search of the theory of everything, the simple concept that will explain also the diagnosis, the etiopathogenesis, the biologic and the treatment of the bipolar disorders. Thank you for your attention.